That stands for Umar Knee again. Acceptance and success of uni knee arthroplasty in Pakistan. So it's Umar Knee again.
Good morning, Bismillah ar-Rahman ar-Rahim. Thanks, Yasser, for always giving me such a lovely introduction. You are a true friend. So, Apton has covered quite a lot. I'll try to elaborate a few more stuff in it, just to give you some of the insight why unicompartmental knee replacement is of benefit. Now, when you're looking into a joint, you take uni knee not as a knee replacement, it's a joint preserving surgery. So you need to have a personality and concept that you're not doing a knee replacement actually. You're only resurfacing the medial side of the cartilage. You're preserving the ACL, PCL, the meniscus. Doesn't matter, it's on the medial side or it's on the lateral side. So the whole game plan is that you are resurfacing a worn out cartilage to improve patient outcome. Biomechanically, they are better. I won't go into detail. We all know even more than that. This is an old slide. That total knee, second only after disease causing disability. So much common arthritis is. It affects 50% of patients over 65 years of age. As the population is growing older, the arthritis will be quite big in numbers, not only in developed countries, but in our country as well, which is developing. Arthroplasty 30-year result we already know, and the NGR shows 95% survivalship, 8% failure in comparing to that is UK. But when we look at 10-year survivalship on the NGR, the meaning of survivalship is implant that are not revised. But if you look in a different perspective, the same knowledge, you will see that the TKR with different measures, 90-day mortality of TKR is almost 4%. By 4 years, 3 to 4% have non-revision surgery. 5 to 8% have worse Oxford knee score, and 20% of patients are dissatisfied. And I think it's just too much saying that 20%, but I would say it is almost 50, close to that. Majority of patients after total knee, how much top class knee surgeon you are, they do come back with some sort of an issue. It's stiff, it's hurting, there's a pain on the lateral, there's a pain on the medial. So it is definitely psychological element or patient perception toward acceptance of such a big knee when they have this surgery. But survival and success is, if you look into this, it's still considered into a success. Somebody after TKR, if he has an MUA, is considered success. If you do open washout, it's is a success on NGR. Stiffness, pain, they won't consider it a failure. And even if patient with the implant dies, is considered a success. Medical complications, I won't go into detail, Apton already covered. But despite that fact, total knee replacement is a gold standard, and I also believe in that, that if somebody has got a tricompartmental osteoarthritis, a TKR is a very good operation, no doubt about that. But what should we do when it comes to a single compartment? You have a 55-year-old male or a female, bone on bone medial side. And in that case, I think either you need to do an arthroscopy, which is not successful. Proximal tibial osteotomy is an amazing surgery, very good result, but you need to have a personality of osteotomy. Not everybody is an osteotomy surgeon. Or we have an option of uni. Unicompartmental, when I came to Pakistan, a lot of patients came to me and I was surprised that I was given this impression that in Pakistan you don't see patients with single compartment arthritis, and actually it was the other way around. I saw more patients with single compartment arthritis than I was expecting, comparison to England. So why there is a high revision rate in England? There are two main factors. First of all, UK is easy to revise. So the surgeon who is not used to doing uni knee, when he see patient with a painful uni, discomfort comes, he will send the patient back, maybe put a steroid injection, and after maybe third or fourth trip, he will say, okay, I think your uni is disturbing you, let's take it out and put a total knee. Second, which Apton covered, surgeon experience. Somebody is doing TKR more than 25 a year has got much less chance of failure comparing to those who's doing less than 25, and that goes to anything. You are doing ACL reconstruction 5 year, your result will be not as good comparing to somebody who's doing 200 a year. But this is another thing. Somebody comes with you, a patient like that, with a very good looking total knee replacement. All the bloods are normal, no pain, discomfort is on the surrounding area, and she is dissatisfied. No matter how much she comes to you, you will be very, very unlikely to offer her a revision knee because it's much more complicated to revise a total knee to a revision knee, which Zishan loves to do. So present, we have now new designs, we have new data. So these are the data recently, not new, but fairly new. Survivalship of uni knee is now much better, 90 to 93% by Coscino, published in International Orthopedics. And Journal of Arthroplasty showed survivalship of 90%, so quite a good at 20 years. And the popularity is getting much better. In America, Australia, and other countries, the popularity and the volume of uni knee replacement is getting more. Launch of uni knee in Pakistan, I was very keen and I pushed quite a lot, and I'm thankful to the companies who supported us. We brought the uni knee in 2018. Fixed bearing, cemented. This was my first uni knee in Pakistan. This guy came from, actually Imran has made this video, and I went to England. This guy came from Quetta, and Zishan, this is 15 days. His stitches were not out. He was absolutely comfortable walking around, and I'll show his video later on as well. Now it's like 4 years down the line, I did his son ACL reconstruction. Zook, uni data of my series, almost 120. I heard I had one revision, maybe more, but so far the follow-up which we done, one patient had revision done. Apart from that, they were doing quite well. These are the indication. Weight. This is the problem which a lot of people discuss about. Should we do uni knee in obese patient? Let's look at, or should we do uni knee in deficient ACL, because that is considered contraindication. So ACL integrity, traumatic, or is it degenerative? If somebody has got a traumatic ACL tear and they got instability and they have medial joint osteoarthritis, yes, I agree, either you should bail yourself out by doing a fixed or you should add an ACL reconstruction. But if it's a degenerative ACL tear, naturally worn, the stiffness is still there, so I think you can easily bail yourself out by doing a fixed bearing uni knee implant. So that's the thing. And the published Murray data in CASTA and Gerard in Clinical Orthopedic Research has proven that. So BMI, a lot of paper published that even high BMI patients, overweight patients do very well. So this is the lady I did in Lahore. She was quite big in size. Accessing a joint in a very big patient, doing a total knee is much more challenging, but doing a uni knee was comparatively much easier. After uni knee, she was able to walk comfortably. She was mentally comfortable to go on the diet plan, do some walking, so she started losing weight, and you will see in the next video. Prediction in Asian. Now, this is something we need to see, that how Asian population has accepted uni knee. So Mirel, 2016, 700 unis, impressive outcomes. Mishra, published in 2020, his series from India, excellent satisfaction, good short-term outcomes. Diagnosis, protocol, I won't go into detail, very simple instrumentation which we have here. And this is first patient, 125 kg female, 3 months, as I said. If you look at the second video, walking quite fine. I think she's now 2 years down the line since I done her. And that's her uni. Let's look at the second case. Another much bigger lady, which we did uni knee. This was during the pandemic. I think 2 years ago, probably again, we did uni on her. Look how she's standing. The confidence of her standing, gait, quads balance, the way she was walking, it does make a huge difference, I noticed, comparing to when you do total knee on them. It's a struggle, it's big, it's very difficult to open up the joint, avert the patella, balance the knee. Another case, 64-year-old male, he was actually showing me that I can run, which was a bit too much, I think. It's not running, but I would say he tried. Now, this is the guy came from Quetta. He was a very big guy. This, I think, I've done in the first few startup time of uni. And he was so happy that he sent me so many patients from Quetta with the same concept that I want you guys to have a uni. And I said, no, you're not, all of you are not suitable to have uni. You need a total knee replacement. So we did uni on him. He's quite tall, quite big, but extremely satisfied. He's, I think, 3 years down the line now. This lady, not recently, maybe I would say a few months back, आवाज जरा बंद कर दो बेटा इसकी.
और बेंड करें.
And if you look how she walks, this is the exciting part. She was really struggling to walk, but after uni knee, she is very happy. And this guy is interesting. He's doing yoga. I have done both sides uni knee, 3 months apart. And he says to me that I do not feel I had a knee replacement. This is his perception. He thinks that I don't have a knee replacement done. So there is no doubt that uni knee plays a very important role. And not only that, you can also do lateral fixed bearing uni. We've done 12. I don't have a big numbers in England. If you look at the other guy, this is fixed bearing we did. I think it was Corin Uniglide. And this guy is now 7 years down the line or 6 years down the line, the second video. We did, and he's extremely happy. So you have to be very, very selective when it comes to the lateral sided uni. You can't just do them to everyone or offer them to everyone. Now I think it's almost coming up to 7 years. This is my old slide. So what's the future? I think robotic knees, which we will cover. Neil Bradbury will elaborate on robotic knees. Are they better than conventional knee? So in Pakistan, I think we are not different from any developed countries. In Pakistan, I don't think so we are different from any race or anyone. These patients are also the same like anywhere else. You just have to be right in your selection criteria. You need to have good surgical skill. You need to be well taught how to do uni, and your patient will be really satisfied. Thank you very much.